स्वप्निल शुरू कर लो. A very good evening to all my dear MOS members and all the ophthalmic fraternity who have joined for today's interesting webinar. It's an initiative of the MOS Young Ophthalmologist group. This program is specially aimed and designed for the freshers and the postgraduates, where the nitty-gritties of the clinical procedure, OPD procedure for glaucoma will be demonstrated. It's a deferred live video session. A small PPT will be first shown, how to go about it by our experts. We have three faculties who are the speakers today. We have Dr. Medha Prabhu Desai, Dr. Tejaswini Varimbe, and Dr. Vidya Chellikar, who are going to speak on the various OPD procedures. And the panelists, we have an expert, Dr. Ashish Thul and Dr. Swapnil Kothari, who is going to have a lively discussion on this topic. So everybody, the postgraduates especially, and those who are not aware of these procedures in the right way, will definitely learn a lot about it. Today we have a moderator, Dr. Sangeeta Kakade. She is also a glaucoma specialist. She is going to moderate the whole session. My close friend, Dr. Rajesh Joshi, and Dr. Rajiv Mundra, the treasurer, are also part of this panel. So over to you, Dr. Sangeeta Kakade, to start the session.
Thank you very much, sir. Dr. Taswala, sir, Honorary President, Maharashtra Ophthalmological Society. Today we have, as sir has said, a topic on basic clinical glaucoma OPD procedures, deferred live demo videos. We have a galaxy of panelists of Dr. Ashish Thul and Dr. Swapnil Kothari. Our esteemed speakers are Dr. Tejaswini Varimbe, Dr. Vidya Chellikar, and Dr. Medha Prabhu Desai. Let me take this opportunity to introduce our first speaker, Dr. Tejaswini Varimbe. Dr. Tejaswini Varimbe is MBBS, DO and DNB. She did her fellowship in glaucoma and general ophthalmology in 1998 from Arvind Eye Hospital, Tirunelveli. And she's done her indirect ophthalmoscopy training and lasers in diabetic retinopathy training from Arvind Eye Hospital, Madurai. She is doing her private practice in Pune since 2000 as consultant eye surgeon with super specialty practice of glaucoma and medical retina. She has presented several papers in state, national, and international conferences, participated in several anti-glaucoma drug trials, and she has given lectures and published articles on glaucoma and diabetic retinopathy at many places. Ma'am, she'll present her short PPT and deferred live video on Applanation Tonometry. Hands over to you, ma'am.
Yeah, thank you. So good evening, everyone. Let me take this opportunity to thank MOS Scientific Committee and Dr. Taswala sir for giving me this opportunity. These all topics are very simple and basic, but very, very important. Classification of tonometers. There are indentation tonometers, applanation tonometers, and non-contact tonometers.
We can't see your PPT, Tejaswini.
Oh, 1 second. Is it visible, madam, now?
Yeah, it's just opening up. Yes. Now put it on the slideshow.
Yeah. Okay?
Yes. Yes.
Yes.
Go ahead.
Yeah, sorry. So these are indentation, applanation, and non-contact tonometers. So today we are going to consider Goldman tonometry, which is commonly used, preferred, and near to accurate, near to perfect. So that's why it is gold standard considering the intraocular pressure measurement. The basic depends on the Imbert-Fick law. Means the weight used is equal to the intraocular pressure multiplied by area applanated. But for this formula, the cornea should be spherical, dry, perfectly flexible and thin, and which is not in the case of a natural human cornea. So this formula has been modified a little bit. Now coming to the technique of the measurement, Goldman applanation tonometry. The first we have to anesthetize the cornea with topical anesthetic eye drops. Then stain the tear film with sodium fluorescent strips which are commercially available, which are sterile strips are available. Then illuminate cornea and tonometer biprism with cobalt blue light from slit lamp. And once we have done these things, then we have to adjust the biprism. We should bring the biprism in contact with the apex of the cornea. So here we have to remember that we have to flatten the surface of the cornea. So there is a gentle contact. We should not press too much and too little. So that we should see the Myers properly, and they should be symmetrical. Up means up, above and below, both the Myers should be symmetrical and same in the size. And once we see the Myers, then we should try by changing the, I will show the diagrams and everything. So we have to adjust the scale so that the Myers inner borders of the upper and lower Myers should be coincide. The fluorescent semicircles are viewed through the biprism, and the force against the cornea is adjusted until the inner edges overlap. So this is the diagrammatic presentation of the Myers and the Goldman applanation tonometry. This is the adjustment knob. So initially we have to adjust at 1, means 10 millimeter of mercury pressure, and then adjust, move this knob clockwise or anti-clockwise so that we should get the exact inner border should overlap, and that is the reading of the intraocular pressure. So this is the scale. Initially we keep the knob at 1, means 10 millimeter of mercury pressure, and then we adjust accordingly. And depending on this, from 1 to 2, there are every line is considered as a, means one line means 12 millimeter, then 14, 16, 18, like that. Now how to interpret? If the inner border of the Meyer exactly if it is coincide, then it is a correct alignment. This one is a low reading, then we have to adjust the scale accordingly. This is high reading, high dial reading. If probe is too low, means we have to adjust the height of the probe. Probe is too low, then we will get this asymmetry of the Myers. If this is the probe, if it is too high, and if there is a excess fluorescein is used and excess fluorescein in the tear film, then we get a very thick Myers and we will not get a perfect pressure reading. Now what are the sources of error with Goldman tonometry? We should put an appropriate amount of fluorescein. So I will show in the video that if excess fluorescein is there, excess tears are there, then ask the patient to gently wipe with a tissue. So wider menisci causes falsely higher pressure estimates. Then this Goldman applanation tonometer, all calculations are based considering the central corneal thickness 520 micron. So depending on the CCT, we may get a false reading. Like in corneal edema, we may get a higher reading, thick cornea, high reading, thin cornea, low reading. Post-refractive surgery, sometime less intraocular pressure is recorded. So we have to be careful and consider the central corneal thickness. Normal is 530 to 540, and different studies suggest a different correction factors. But generally the 0.2 to 0.7 millimeter of mercury per 10 micron. Now deviation of corneal curvature. That also will affect the measurement. If there is a marked corneal astigmatism, IOP is underestimated in with the rule astigmatism and overestimated in against the rule astigmatism. Generally, for every 4 diopter, there is a 1 millimeter of mercury difference. Every month, we have to calibrate the tonometer, and how to calibrate the instructions are given with the machine. Disinfection of tonometer is very important. Goldman tonometry measurement can spread the adenovirus of epidemic keratoconjunctivitis through tear film, then HSV, COVID-19 or HIV, hepatitis virus also. So it's better to disinfect the biprism with a 70% isopropyl alcohol swabs. These swabs are commercially available, and it is important to remove the disinfectant before reuse, as alcohol and hydrogen peroxide can cause temporary corneal defects. And these means let the biprism should be dry before reusing. Now, one more thing, can you share the video? One important thing is multiple contact and long duration contact can damage the cornea, and corneal epithelial lesions we may see. So we should avoid multiple contacts and the long duration contact. So first I am showing the Perkins tonometry video. Perkins tonometer also uses the same biprism, and it is a handheld tonometer. So useful for bedridden patients, for children, and the readings are as good, as perfect as the Goldman applanation tonometer. The similar scale is there, and the biprism is showing. I have stained with the fluorescein strip. I ask the patient to look straight, and then adjust the knob accordingly. Second, can you run the second video, Goldman applanation tonometer? Other things is same important, topical anesthesia or this fluorescence strip. Rest everything is same. Only thing is just open the eye. I think the another video is third video. With 2 fingers, just open the eye properly, and gentle contact should be there, the biprism and the cornea. And then adjust the knob for measurement. Okay. Thank you. The questions, I think we are taking last of the session or now?
Many at the end of the session.
At the end of the
panel
session.
discussion
Okay.
will be doing it. Thank you.
Panel discussion.
Thank you very much, Dr. Waimbe. That
Yeah.
was nicely covered. All the points were nicely covered. I think we
Thank
should
you.
move on to the our second speaker. It gives me great pleasure to introduce Dr. Vidya Chellikar. She is MS and DNB, did her fellowship in Glaucoma in 1998 from Arvind Eye Hospital, Madurai. Then she worked at LV Prasad Eye Hospital for 1 year. She has joined HV Desai Eye Hospital in 2000 as at present is HOD of Glaucoma department. She is a PG teacher and guide. She's presented several papers in state, national and international conferences. She has 7 to 8 publications in peer-reviewed journals of national and international level. Good evening, ma'am. I hand it over. She will present her topic on short and deferred live demo and video on Gonioscopy. Over to you, ma'am.
Yes, thank you. Thank you for the introduction. And I thank MOS Scientific Committee, Dr. Taswala sir, for giving me this chance to participate in this program. I'm just sharing my presentation. Aparna. Can you see my presentation?
Yes, yes, ma'am.
Yeah. Slideshow. Just a second, it's not going to slideshow. It is coming.
Anmol, you can share from your end if it is a problem.
Ma'am, can I request if you can put on the slideshow from the top side? It is showing slideshow and select.
Yes, yes, there is. Yes, I'm doing that.
Now we can see actually. But
Yeah.
it's a last
slide. Yes, yes.
Yes,
I will go to the first slide. Yeah.
Yes, first slide you have to go and then you can.
Yes, yes, yes.
Double click.
No, I can do it, but somehow it's not happening from the beginning. Yeah. Yes, now it's seen. Yeah. I think
Yeah,
now
it's
it is seen. No? Yeah.
Yes, yes.
Yeah. Sorry for the, this difficulty. Okay. So again, thank you, Dr. Taswala sir, for giving me this opportunity. I will be talking on gonioscopy. So gonioscopy is a technique that is used to visualize the angle of the anterior chamber. A regular slit lamp examination does not allow the angle of the anterior chamber to be seen because the angle that goes, the light that falls into the anterior chamber angle is, undergoes total internal reflection and hence is not visible to the observer. So the use of an external gonio lens allows this light to be coming out of the eye and allows the examiner to visualize the angle. So this is the basic principle of gonioscopy and the gonio lenses. So there are mainly two types of gonioscopy, the direct and indirect. So in the direct lens, with the direct gonioscopy, you can see the angle directly. That is the angle that we focus is visible directly, but with an indirect ophthalmoscope, the angle, the rays from the angle fall onto the mirror here and they are reflected from here. So it is an inverse image, or the image is from the opposite angle. This is called indirect ophthalmoscope, indirect gonioscopy. So there are few differences. As I just said, here the direct angle is visible, here a mirror image is produced. And here mostly both the eyes can be examined simultaneously and there is a more panoramic view of the angle. But with indirect ophthalmoscopy, usually based on the lens that is used, one quadrant is examined at a time. So that's the main difference between the two. And another advantage of indirect gonioscopy is that we can perform indentation gonioscopy. So the prototype direct gonio lens is the Koppe's gonio lens, and we will not go into more details because it's not very commonly used in the OPD procedures, except that now it has gained importance as it is being used in several angle surgeries. So the indirect gonio lenses, there are two types of lenses, the indentation lens and the non-indentation lenses. The indentation lenses are the ones which are more commonly used. There are the typical Goldman lenses, which are in various lenses are available. Single mirror, 2 mirror, 3 mirror, even 4 mirror Goldman lens is now available. The only thing here is that it requires a coupling agent when we are using it on the patient's eye. So because of the difference in the corneal curvature and the curvature of the lens, the lens that we insert on it, the curvature is different, hence there is a need for the coupling agent. And indentation lenses are, several lenses are available. Most commonly used are the Zeiss 4 mirror and the Sussman lens, and they are having a similar curvature as the cornea, hence they do not need any coupling agent like any viscoelastic. They can be placed directly on the cornea. And the 4 mirror indentation or the 4 mirror regular Goldman lens, they allow the examination of all the 4 angles. I mean, we do not have to rotate the lens. If it was a single mirror or a 2 mirror gonio lens, like in this case, that this is a 3 mirror lens on the right side that you see. So then we require to rotate the lens when we are examining the patient's angle. But with the 4 mirror gonio lens, 4 mirror Goldman lens, or these Zeiss lenses, because all the 4 mirrors allow to examine all the 4 angles, but one by one, one after the other. So a typical angle, let us just go through the anatomy of the angle here. So this is the root of the iris, as we can see. So the root of the iris, then comes the ciliary body band, which may or may not be seen in all the patients. Then comes the most important landmark in the angle, that is the scleral spur. It is seen as a white line, thick line, and shiny line sometimes. And beyond that is the trabecular meshwork, which is divided into a posterior pigmented trabecular part meshwork and an anterior non-pigmented trabecular meshwork. And after that, the most anterior structure is the Schwalbe's line, which is the end of the Descemet's membrane. So these are the angle structures. So when we are doing gonioscopy, it is very essential that we know the angle anatomy and all these structures in order, so that we can know how much of the angle is seen, and then based on that, we grade the angle. So as I just was telling you, this is the corneal wedge. This is a very important thing that has to be identified before we start the gonioscopy. So this is the anterior corneal epithelium, and this is the endothelium. So this is the epithelium and this is the endothelium, and the point where the two beams meet, it's called the corneal edge, and that represents the Schwalbe's line. So once we identify the Schwalbe's lens, then immediately behind is the trabecular meshwork, then the scleral spur, then the ciliary body band, and the iris root. So these are the order of the angle structures that we see. So okay, trabecular meshwork, the scleral spur, this white line here in between. I will show you in further photographs also. This white line here, you can see, this is the scleral spur. And this black dark band is the ciliary body band. The ciliary body band may not be visualized in all the patients, but sometimes in very high myopes or aphakic patients, it is easily visible. And this is the last structure, is the root of the iris. So this is very easily identified. So coming to the indentation gonioscopy briefly. So here we use a Zeiss 4-mirror lens. And once we examine the angle and find that the angle is narrow, then we do the indentation technique. So indentation consists of applying pressure with the 4-mirror lens very gently on the center of the cornea, so that the aqueous is displaced. So when we apply some pressure, aqueous is displaced, and that goes out through the angle, and that will sometimes open up the angle. So if it is an oppositional closure, this angle opens up after indentation and also exposes synechiae if there are any. So if it does not open on indentation, that means it is not an oppositional closure, it is a synechial closure. So that is the meaning of indentation gonioscopy. So again, coming to the angle structure. So this is a diagrammatic representation, and this is important to grade the angle. So when, so again, in this diagrammatic representation, you can see the corneal wedge. Just a minute, I'm showing you. So the corneal edge wedge here, this is the Schwalbe's line. So anterior non-pigmented trabecular meshwork, the pigmented trabecular meshwork, the posterior trabecular meshwork, this is the scleral spur, the ciliary body band, and the root of the iris. So when we see all these structures, it is a wide open angle. So as the angle becomes narrow, the number of structures that we see can be reduced, and we do not see the posterior most structures. So as you can see, as we are moving to the right, one by one, these structures are not being seen. So in these last two images, as you can see, only the Schwalbe's line is seen and a small amount of anterior trabecular meshwork is seen. And in this, it is, I mean, no other angle structure is seen. It's only the root of the iris and then the corneal beam. So this is a totally closed angle. So this, is important to grade the angle. And there are several classifications which are available to grade the angle. So there is a Shees classification. So basically all these classifications are based on the structures that we see. So whether we see all the structures or whether we do not see any particular structure. So based on that. So for example, when all these structures, what I showed you in the previous slide, when all are visible, it's a wide open angle. When the iris, okay, so there are several classification systems. This is the Shees classification, and this is the Schaffer's classification. So Schaffer's classification makes use of the structure visible as well as the angle width, the angular width in terms of degrees. And the Speed's classification considers more anatomy structures at the angle, like the iris insertion, the width of the angle, the peripheral iris configuration, and the pigmentation. But very practical classification is this, where again, when all these structures are visible, like the ciliary body, the scleral spur, and the posterior trabecular meshwork, all these constitute an open angle. So a middle 1/3 of the trabecular meshwork, that is also an open angle. When only the anterior trabecular meshwork is seen, or there is no trabecular meshwork is seen, or only Schwalbe's line is seen, these three constitute a narrow angle. So why do we have so many, grading systems? So grading of the angle is done in an attempt to correlate the angle structures visible with the potential for angle closure. That is why it is important to see how many or how much of the angle is visible. The more lesser structures are seen, the more narrow is the angle. This eye is more prone for angle closure. So that is the importance of grading the angle, identifying the angle structures and grading the angle. So okay, so what are the indications of gonioscopy? So ideally, gonioscopy should be done in all the patients who are suspected to have glaucoma, all the patients those walking into the glaucoma clinic. But maybe sometimes in want of time, this may not be possible. But indentation, the gonioscopy has to be performed to identify the type of glaucoma, whether it is an angle closure glaucoma, to see whether it's an open angle glaucoma, or see if it is any kind of a secondary glaucoma. And also to find out abnormal deposits like the pseudoexfoliation pigment, foreign body, or any other abnormal structure, to look for neovascularization of the angle and the neovascularization of the angle, to identify any foreign body, to see for any tumors of the iris or any abnormality. So basically it is very, very helpful to classify the type of glaucoma. The very important contraindication for gonioscopy is recent trauma to the globe. Any recent trauma, we should never try gonioscopy because it will increase the damage to the eye. Of course, these are very severe conditions where we should not try gonioscopy. And another very important condition is immediate post-op. So probably we don't require it very much, but in sometimes secondary glaucomas like pseudophakic glaucomas or some secondary glaucomas, we may need to do gonioscopy to identify the cause. But there also you should be very careful, especially in the immediate post-operative period. So now coming to the technique and the procedure of gonioscopy. So before we start gonioscopy, it's very important to explain to the patient about the procedure. You have to tell them that is a lens which is going to be inserted into the eye, and you should make the patient comfortable. And before we start gonioscopy, it is important to do a slit lamp examination to know the basic pathology in the eye, whether it's normal or abnormal, to look at the depth of the anterior chamber, see whether it is shallow by using the von Erich's method, and also look for any anterior abnormalities in the slit lamp like synechia or pupil reaction, some iris atrophy. All these may guide us or give us a hint of what we are going to expect in gonioscopy. So coming to the actual technique, as you can see in this first picture on the left, anesthetize. After explaining the procedure to the patient, we anesthetize the patient's eye with the help of a topical anesthetic, and then seat the patient comfortably at the slit lamp. The patient's head has to be, in contact with the headrest here, and gently pull the lower lid of the eye. This is the Gonio 4-mirror lens that I'm using, Goldman lens. So we have to fill the concave face of the Goldman lens with the help of a viscoelastic. We should take care that there is no air bubble. Sometimes the bottle may contain air bubbles, so we should avoid air bubbles coming into this surface of the lens. So gently pull the lower lid and insert the lower edge of the Gonio lens onto the lower scleral part of the eye. So gently insert it there and then ask the patient to look straight. First, we are asking the patient to look up. After we insert the lower edge, ask the patient to look straight and gently tilt this lens onto the surface of the cornea. And now the patient is looking straight. The lens is directly onto the anterior surface of the cornea. Fix your hand. You can support your hand with your elbow with some support to make your hand stable. And so the eye during gonioscopy has to be in the primary position. The patient has to look straight. And of course, now the another requisite is to have a dark room. Here the room is bright just for recording, but otherwise the gonioscopy would require a little dim lit room, if not a very dark room, but a dim lit room, because in a dim lit room the pupil is in its relaxed position, in its primary position, we can say. So that will allow us to maximize the chances of identifying an angle closure. So the same thing that I explained, let us see the video. So once the lens is inserted and patient is seated comfortably looking straight ahead, then we see So after this, now we have to reduce the beam of the slit beam. We can use up to 2 to 3 millimeters length of the slit beam, a dim slit beam preferably. And then slowly and gently focus the beam onto the angle, not allowing the light to fall onto the pupillary area, because light falling in the pupil can artificially constrict the pupil and can artificially open the angle. So care has to be taken that the light does not fall on the pupil. A narrow beam directly focused onto the angle is desirable. But for beginners, you can use a little brighter beam or a broader beam, focus onto the angle, and then again reduce it. Wait for some time for the pupil to come back to the normal size and then examine the angle. So, and then examine one by one all the 4 angles. Focus on the angle. So in this angle, we could see all the angle structures. That's a wide open angle. Sometimes the nasal and temporal angles, they are a little narrower than the superior and inferior angles. So there may be slight difficulty when you are examining the nasal and temporal angles. They may not be as easy to see as the superior and inferior angles. So one by one, all the 4 angles, I think here I have shown up to 3 angles. So all the 4 angles have to be examined one after the other. So here is another patient. So again, a very narrow slit beam is focused onto the angle area. So here you can see that the iris configuration is slightly convex. This you can see here, this beam is slightly convex. So this can be made out more clearly when you're practically doing it. So we should also always notice the amount of convexity of the iris. And here you can see that that earlier angle that was closed in this video. This is the nasal angle. Here you can see it is narrow and there are few synechiae in between. Not very clear, but see here, this part, and here there is one here and there's one more down. So even here now you can see the angle is just an anterior trabecular meshwork is visible. It is a narrow angle. And the last angle now, the temporal angle. So you can see no angle structures are visible. It is a narrow angle. So this is how we see all the 4 angles with the narrow beam. So, so these are examples of an open angle. So here all the structures are visible. The iris root, ciliary body band not very clearly visible. The scleral spur, this white line is the scleral spur. The pigmented trabecular meshwork, the slight, lightly pigmented area in front of it is the non-pigmented anterior trabecular meshwork, and the last line would be the Schwalbe's line. So here again, this is the pigmented trabecular meshwork, and sometimes the Schwalbe's line is so thin and so lightly pigmented, it's difficult to make out. But with experience, you can definitely identify the Schwalbe's line. So this is a closed angle. Here you can see no angle structures are visible. So now just to show you some abnormal findings in gonioscopy. So in pseudo exfoliation glaucoma, as we all know, there is a pigmented Schwalbe's line. So you can see here pigmentation of the anterior most Schwalbe's line. So in pseudo exfoliation, we also get to see sometimes increased pigmentation of the trabecular meshwork, although here it's not so well pigmented. So another important condition is the new vessels in the angle, neovascular glaucoma. So where we see synechiae, broad-based peripheral anterior synechiae, as well as new vessels and blood in the angle. So new vessels are seen like this, crossing the angle. This is a neovascular glaucoma. So foreign body in the angle, very important when we suspect trauma, and after, not immediately after trauma, but once the eye is, inflammation is settled and the eye is quiet, we can see the foreign body here in the angle. Then angle recession in cases of trauma. Here we see a very broad-based ciliary body band. Because the angle is recessed, the iris is also recessed. We see a broad ciliary body band. That is the sign of angle recession. Pigmentary glaucoma, where we see very excessively or a heavily pigmented trabecular meshwork, as you can see here. And one important condition that we have to differentiate, and that is a very often confusing condition, is to differentiate the peripheral synechiae from iris processes. Iris processes are fine, strands coming out of the iris and crossing all over, crossing the angle on the whole. So they are normal structures, and that they are not abnormal structures. That is what I want to say. This can be seen in, it may not be seen in all the patients, but this is sometimes seen in patients with open angle glaucoma. And this is not to be worried. This is not an abnormal condition. But in contrast, the peripheral synechiae, they can be fine synechiae, Gonio synechiae, or peripheral broad-based synechiae. They can be continuous. They can be, intermittent synechiae, but they are the peripheral anterior synechiae. So these were some of the abnormal conditions. So thank you so much.
Very nicely covered.
Yeah, thank you.
Very
Sir.
nicely covered topic, ma'am. Wonderfully covered with all in a simplified way. Thank you very much, ma'am.
Thank you.
So our last speaker today is Dr. Medha Prabhu Desai. She has 30 years of experience as a glaucoma consultant. She did her medical graduation and post-graduation from BJ Medical College, Pune. She did her fellowship in glaucoma and anterior segment and medical retina from Shankara Netralaya, Chennai. She's an ex-glaucoma and cataract consultant from in Sri Ganpati Netralaya, Jalna. From 1994 onwards, she is working as a consultant at Prabhu Desai Eye Clinic, as well as honorary ophthalmic professor of ophthalmology, Bharati Vidyapit Medical College. The books that she's authored is Atlas of Ophthalmic Nerve Head Evaluation, JP publication, and Dilemmas in Glaucoma chapter on glaucoma progression by Springer publication. She's done research in international phase 3 studies, bioequivalence of glaucoma medications. She's a faculty for national and international conferences. She's presented papers and presentations at AO, AIOS, GSI, U-Retina, and ICGS. To name a few, American Academy of Ophthalmology 2011, autologous scleral graft for post-trap blade leak with scleral melt, and ICGS 2014, RGC defects in POAG and PSCG, NVG in patients of PDR. Welcome you, ma'am. Hand over to you. She will present her topic on short PPT and deferred live demo video on optic nerve head assessment with 90D lens. Hand over to you.
Thank you, Dr. Sangeeta, for a nice presentation. I would like to thank MOS and our president, Dr. Taswala. I'll start my presentation on clinical evaluation of optic nerve head, which is a mainstay of any glaucoma diagnosis. So if you have a suspicion that the ONH might be glaucomatous, then you need to investigate with further tests. So examination of the optic nerve head in glaucoma is the simplest and most overlooked skill in ophthalmology. So clinical evaluation can be done by direct ophthalmoscopy, but it has limited advantages because it lacks stereopsis, and can be done with the help of slit lamp biomicroscopy. With the help of non-contact lenses, you can use either 60D, 78D, or 90D. 90D is the most popular lens. Also, Goldman and Zeiss 4-mirror can be used. The central part can be used for this. This gives us an advantage of stereoscopic examination. And once you see this, you can have a detailed drawing of the optic nerve. So I'll show you a short presentation, short video on this. So the most important thing is that you need to have your ocular and the slit lamp in coaxially illuminated. You need to have, if you have a camera also attached to it, it's well and good. You need to explain to the patient that what you are going to do. It's not a contact thing. So you can tell the patient that it will come near your eye. You have to have support for your elbow, or I usually take the support of this headband itself. You have to ask the patient to look straight ahead in a neutral position and not to look at the light source, because if the patient looks at the light source, you would be seeing the macula and not the optic nerve. The usual thing is that if you see a retinal vessel, follow the retinal vessels, see where it is branching, and it should go towards the optic nerve and then concentrate on the optic nerve. Initially, what you can do is, although when you see its open angle, you can dilate the patient and start seeing with 90D, which will help you a lot in seeing your patients undilated also with the help of 90D. The most important thing is the ambient light. So ambient light should be very low. You should actually switch off all the lights. So I'll show you this video. So this is, I have explained the patient. The room lights are switched off. Now I'm holding the 90D lens in front of the eye, a few centimeters away from the eye. Ask the patient to look straight into it, or towards, sometimes you can ask the patient to look at your ear or the knob over here. So it will actually center the optic nerve where you are seeing. So I'm recording this, which the recording I'll show you later. So I'm clicking the photographs also for future references. Another important thing is that you have a knob over here where you can reduce the height of the slit beam to coincide with the optic nerve head margins. So that will give you diameter, and I'll show you how to read the diameter. So I still reduce the height of the beam. And this, I'm recording a video, which I'll show you afterwards. Okay, so how to measure the optic nerve head size clinically? So this is the lens, and you have a scale on each and every slit lamp. So you adjust the knob over here and read the scale over here. So this needs to coincide with the optic nerve head margin over here. So this is how it should look. This is a diagrammatic representation of the same. And the magnification is, if you are using the Vogue lenses for 60D, 78D and 98D, it is like this, because the Vogue and Nikon will have a different magnification. So you need to know which magnification should be applied to the lens which you are using. And here you can read and multiply by this multiplying factor to know the exact size of the optic nerve. So this is again a video of the optic nerve which I had recorded. So you can see, you can follow the retinal vessels and see exactly the optic nerve is, and reduce the beam size. So you can also use red-free light to see the RNFL defects with the 90D. So here you can see that the optic nerve is there. There is a notching over here, and you can see some darkness over here. The retinal fiber layers is not clearly seen. But if you switch on to the red-free, you can see that there is a big RNFL wedge-shaped defect over here and a superior defect also there. So here clinically we can say that this patient is having a moderate glaucoma, and we need to investigate this patient further. So we will see what are the things we need to see. The most important thing what we have to see is the disc size, the neuroretinal rim, the vessel pattern, RNFL defects, and any peripapillary atrophies there. So disc size is, you can measure with the slit beam. Neuroretinal rim, we will show you how to find out the neuroretinal rim. The most important thing is that we have a population variation. There can be small size disc, mid size disc, and large disc also. And this is why this is important, is because the small size disc will have a small cup, mid size will have a larger cup, and definitely large size cups with disc will have a larger cups, which can be totally physiologic. So we should identify where our patient is there, whether he has a small or mid size or large disc. So what is neuroretinal rim? So first you need to identify the age of the disc, and after that observe the blood vessels in the cup and the disc and where they are traversing the neuroretinal rim. And with this you can find out where exactly is the neuroretinal rim. So where they change course on the neuroretinal rim, that is the inner cup margin, and you know where the disc margin is. So it becomes easy to identify the neuroretinal rim. So here are some signs which you can identify. So here this is a focal atrophy or notching. Here you can see that there is a bearing of the circumlinear vessel over there. Here you can see that there is a fenestrations in the lamina crepullosa can be seen because of the loss of neuronal tissue, which is also called as laminar dot sign. Next, again, here, this is typical of bayoneting of the disc vessel. You can see the disc vessel has dipped into this because there is a loss of tissue and it is coming over the neuroretinal rim and traversing further over the retina. So this is notching or with the bayoneting of disc vessel. This is the thinned out NRR. Here you can see the NRR is here and the disc cup margin is here and the disc margin is here. So the NRR has literally thinned out in the temporal and inferior temporal areas. So the next thing is Pallor and Cup Discrepancy. So this is what we see as a Pallor, but the cup margin, if you see the NRR, is much more bigger. So this is called as Pallor Cup Discrepancy, and this is a pathognomonic sign of glaucoma. So the most important thing is that once you see the disc, you should draw. You should make a habit of drawing each and every disc. Then only you will know whether you can see the progression, you can monitor the progression, even you don't have fundus photographs also. So how to draw a disc? As I said, the most important is follow the vessel, see where they are bayoneting, mark it. This is a bare circumlunar vessel, so that also you need to mark it. And a wedge defect, how much you can see there, that you need to mark on this. Here you can see that the area over is sloped over. So for sloping, we use the sign like this. NRR is obviously thinned out over here. So for any clinical evaluation of optic nerve, this is the method which we follow. Documentation is also very, very important. And we need to investigate these patients with the help of OCT or visual field if there are some signs which point towards patients as a glaucomatous optic neuropathy. Thank you very much.
Thank you, ma'am. Good photographs as usual. You really have good collection of photographs and data.
Thank you.
Very nicely covered, all three of you. All the topics were so nicely taken up. Now we'll have a lively discussion on this topic. We'd like to have the views of the panelists also regarding this, what all their view is. So over to you, Dr. Sangeeta, to introduce our co-panelists, and then we have a lively discussion.
Yes, sir. Yes, sir. It gives me a great pleasure to introduce our first panelist, Dr. Ashish Tul. He's a glaucoma, cataract and refractive surgeon doing his private practice in Nagpur from 2004. He has done fellowship in general ophthalmology from Sankara Netralaya, Chennai in 2000. He's worked as glaucoma trainee consultant at Sankara Netralaya. He was an associate consultant at anterior segment and glaucoma at Ganpati Netralaya, Jalna. He has trained many PGs and fellows at SGN. He has over 115 presentations of regional and international meets. He has articles in peer-reviewed journals and other scientific publications. He's performed live surgeries of regional meets. He is MOS Scientific Committee member as well as Vidarbha Ophthalmic Society President. Let me introduce our second speaker, second panelist, Dr. Swapnil Kothari. He is MBBS, he's done MBBS from KEM Mumbai, DNB from Sankara Netralaya, Chennai. He is FAICO and MNAMS. He is working as consultant ophthalmologist and cornea specialist from 2009. Has performed more than 20,000 cataract surgeries, including more than 18,000 phaco surgeries, mostly under topical anesthesia. His special interest is in lamellar corneal surgeries and other ocular surface surgeries. Has done many presentations and publications. He is a reviewer and editor of Indian Journal of Clinical and Experimental Ophthalmology. He is a reviewer for Asia Pacific Journal of Ophthalmology for cataract and cornea specialty. Has received many honors and awards and done a lot of community work. So I think after this introduction, let us have question answer sessions with all the eminent speakers and the panelists.
Yes, definitely. You have the questions on the Facebook or the YouTube, otherwise we'll start the session. As you are going through it, I'll just ask the first question to Dr. Tejaswini regarding the illumination arm of the slit lamp and the placement of the applanation tonometer. How does a pressure go about? Tejaswini, are you there?
Yes, sir.
Yeah.
The illumination, we should use a blue illumination, cobalt blue, and the prism should be exactly perpendicular to the cornea, and the slit lamp beam is around 30 to 40 degree sideways. Means we have to keep the beam from the side.
Okay. The illumination is about 30 degrees from there, and you have the cobalt filter on. Correct. So this is the way I think the fresher should go about it.
And keep the illumination at the highest, means maximum possible.
Absolutely.
So
And
there is
again,
one question on YouTube, sir. It goes to Dr. Vidya. I'm not able to comprehend the question, but it says that Dr. Vidya, injecting the root of trabecular meshwork, is it enough surgery? From YouTube. Maybe he's talking about goniotomy, ma'am.
Right.
Yes, injecting the trabecular meshwork.
Yeah, it's written like that. Maybe he's.
Anyway, just explain about the goniotomy part.
There is a surgery called viscocanalostomy where we inject the viscoelastic through the Schlemm's canal. That is one kind of surgery. The other angle surgeries, as you just now said, goniotomy, again, we use a direct lens, visualize the angle directly and use special, techniques to open the, trabecular meshwork over in there and then allow the flow. So those are surgical techniques. I think that is that's different.
And what is your view about this recent anterior segment OCT versus gonioscopy? The pros and cons?
That was one question I was expecting actually. So yeah, as I just said in my talk, initially I said slit lamp evaluation of the anterior chamber depth using von Herrich's techniques just gives us some idea whether it's a very deep chamber or a narrow shallow anterior chamber. That can give us the first indication whether it could be a narrow angle glaucoma. But of course, it is not a confirmatory technique. We have to do gonioscopy to evaluate, and gonioscopy is definitely the gold standard technique than the anterior segment OCT. Anterior segment OCT is a non-contact technique, very easy, not demanding to the patient. It is just like the other OCT for the posterior segment. It is an objective method. The technician performs the technique, but there, it's not so easy to identify the, angle structures. The most important structure, even in ASOCT, is to identify the scleral spur, which is possible in some patients, but it may not be exactly possible to identify the scleral spur. It may give us some idea about the, whether it is narrow or open and many other angle abnormalities and even the anterior segment abnormalities, but you cannot make out, synechiae. Synechiae also maybe, I don't know, I have not seen a synechiae on the anterior segment OCT, but then see increased pigmentation and some other changes that are, just seen directly with our visualization of the angle, those cannot be picked up by the ASOCT. So in my opinion,
you won't be able to see anything in the angle basically on anterior segment.
Yeah. It is, it can give us some rough idea about what is there in the angle and the, depth of the angle, the depth of the angle recess and all that. But it is not a substitute for a proper gonioscopy.
Yes, ASOCT can be just a complementary to gonioscopy. Yeah,
maybe
it's very easy for us to explain to the patients. Patients understand very easily what is going on. So it's for explaining patients, it's really good.
And the decision for treatment should depend on gonioscopy. But in COVID period, especially in the first and second wave, ASOCT helped a lot. Because that time we were not doing the gonioscopy.
Non-touch.
And, so in that period, it helped a lot to me. In COVID.
Even after doing PI, you can show the patient how the angle has opened up. So that also helps. Understanding of the patient is for ASOCT is really good.
Very nice tips. I would like to ask Dr. Ashish Thul his view on all the three procedures. What pearls he would like to add? Yeah, he and of course Swapnil Kothari later.
Thank you, sir.
Ashish?
I hope I'm audible.
Yes, very much.
Yes.
Yeah. First of all, I would like to congratulate all the three speakers. Excellent presentations. I'm sure the postgraduate friends who have logged in would definitely be benefited by those presentations. Practical tips were given. Just one or two points I would like to add up. whatever examination techniques we are doing nowadays, as was mentioned, we have just passed through the COVID period. No, a small tip that we are using for all patients. No, we put a Meditape on the upper border of the mask, so that whenever you have to do any kind of examination, for example, you use a slit lamp biomicroscopic examination, the lens tends to fog up. So it's a good idea to put a Meditape on the upper border. That's one point. And as related to Gonioscopy, I would want to pass on the message to our postgraduate friends that do it as a routine. The more number of gonioscopies you do, you would be able to identify the normal angle structures, the variety in normal angle structures that is there, how a angle looks in a young myope, how it looks in an aphakic patient. Once you are able to identify normal angle structures, then you will gain experience, and then you will be able to practically learn the subtle things, that how to use those proper testing conditions to differentiate between an occludable, non-occludable angle, and then it will be a routine for you. So that was one more thing. And as related to optic disc examination, ma'am has covered everything to the T, so nothing much to add up there.
Thank you.
So nice of you. What about Swapnil? Any tips and pearls you'd like to add?
Thank you. First of all, I would like to thank MOS for giving me this
Your voice is breaking, Swapnil. If you have logged in two devices, cut off. And you can put your
the
video off
presentation
and
is excellent, but I would just like to add that these.
Yeah, go ahead.
Am I audible?
Yes,
Yeah,
yes.
you are audible. It
Yeah.
was breaking. So if you have logged in two devices, you can log off to one and put your video off in case.
Pardon me, sir.
Yeah, now it is okay. Go ahead. Go ahead.
Yeah. First of all, I would like to thank MOS for giving me this opportunity. As Dr. Ashish has already said, all the presentations were excellent. But I would just like to say that these were not only for PGs, but many of our practicing ophthalmologists who routinely don't do gonioscopy, as well as routinely are not very conversant with 90D. I think this kind of presentations are extremely useful for them also. Just one small thing about that OCT versus gonioscopy thing that was going on was gonioscopy affords you a 360-degree view, which is very, very difficult to get on most of the OCTs. On OCTs, you will see one area or at the max 4 areas or 5 areas, the line scan that you are doing. While gonioscopy affords you a dynamic view of all the angle structures 360 degrees. So as far as my understanding goes, I don't think there is going to be any technology which is going to replace well done indentation gonioscopy anytime in the near future. As well as if you plan to, kind of venture further into angle surgeries, then knowledge of a basic good gonioscopy would be most essential before you can think about any of those Kahuk blade and all those surgeries that ma'am was talking about.
One more question I would like to ask everybody, all of them, is which type of a gonio lens would you tell the beginner to buy? A fresher who just come out and has easy for him to learn also and easy to use. Each one of you can answer one by one, please.
So I would advise a 2-mirror or a 4-mirror gonioscope. 2-mirror, which will allow 2 mirrors, 2 angles to be examined once, and you rotate it, then you see the other 2 angles. Nowadays, a 4-mirror Goldman lens is available, quite as good as the other lenses, but all the 4 angles are visible one by one. You can see, there is no need to rotate. Very easy to insert, very easy to fix, and examine the angle.
Yeah, others, please.
I will suggest 4-mirror is easier. No coupling fluid is necessary, and indentation gonioscopy is also easy with 4-mirror. And at the same time, we can all the 4 angle without rotation. We can see all the 4 angles. So I think Zeiss 4-mirror is better.
Yeah, even I will say that Zeiss 4-mirror is really good. I have 2-mirror, 4-mirror, handheld 4-mirror indentation, and even I have one 6-mirror also. Oh. So 4-mirror is really good, but out of all.
No, I am talking about the 4-mirror Goldman lens.
Yeah.
Yeah. I was talking about the Goldman 4-mirror lens, which uses a coupling fluid, the
Yes.
viscoelastic. But I think what others are talking is the 4-mirror Zeiss, which is the indentation, gonioscope. So I think first the beginner has to get used to doing the gonioscopy with the regular, Goldman lens with the viscoelastic, which will provide better stability. They can maneuver the, and the patient cooperation is less in this, which is required is less, because in a Zeiss 4-mirror lens, the patient's cooperation is also important. We have to also, place it properly without air bubbles going in.
It
I think
slips
a little
sometimes
difficult
without
technique
coupling
than
fluid.
the one. Yeah. I think once they are comfortable with using the viscoelastic with the Goldman lens, they can move over to the Zeiss 4-mirror indentation gonioscopy.
Yeah, Ashish and Swapnil.
Yeah, I agree with that point. If you are doing it regularly, there is no substitute for the indentation type of lens. Whether you use a handheld one or a one with the handle, the Portioner type is totally your take. But if you are wanting to go into gonioscopy, start learning it, as Dr. Vidya said, best way is to get the one with wherein you have to use the coupling fluid, because ease of use would be good. You won't be pressing too much. You won't have to hold your hand very lightly or tightly. The patient comfort also will be good. And the basic idea to identify those angle structures, that would be taken care of while learning. So once you have done that, only precaution that has to be taken there is make sure that there is not even a small air bubble when you are putting in the lens, because that will hamper your view. And once you are comfortable with this, you shift on to the indentation type ones. There, the initial learning period, in initial learning period, you will have, sometimes you will have a very light touch wherein your contact will go away. Usually, initially, we tend to press more and you'll have those DM folds, which will hamper your views. So with few tries and doing it over a few days, you will get the hang of it. And as a routine, the indentation type is the better one.
I asked you this question was basically because 80% of the private practitioners don't do regular gonioscopy unless they see something. So that is why this is a very important point, what to buy and how to do. So very well put up, everybody, each one of you. Swapnil, your take?
I think when you are a PG as in an institute, run behind whoever is taking care of the instruments in the PG department and get whatever is available in your hands and start with that, rather than thinking we'll buy this indentation one or the other one. I think for a long-term investment, indentation one is the thing that you should go for. But as a PG, first start with whatever is available, and you can graduate to something else later on. That is all. That can always be done. But the start is required.
Yeah, very nicely put up, because
for beginner, it is difficult to see where is the angle, what I'm facing when I go to Bhati. So the most important thing is you first concentrate on the pupil, then slightly go peripherally, and then see where the angle, where is the iris, and then start seeing. So that would be the first day. Then slowly you go and find out the angle straight away. And anytime if the beam falls into the pupillary area, just switch off the beam for a few minutes, 30 seconds, actually they say. Switch off the beam for 30 seconds and then go again in the angle and start seeing.
Yes, very, very important points. Huh? Anybody else who would like to say? Otherwise, we'll ask the next question to the panelists. Any inputs? Yeah. Again, regarding the applanation tonometer, there are imported applanation tonometers and the Indian ones. What would you tell a beginner to buy and why? Each one of you, in short. See, a beginner is establishing his practice. He wants to invest. It should be a one-time investment, or initially you should go in for a cheaper one and then graduate into the higher ones.
I have a hack straight applanation tonometer, which I had bought in 1994 when I started my practice in Pune. It is still working. It is in my room.
Correct.
Everything is still good, but whatever Indian we had bought for our assistant optometrists, they all go within 3 to 4 years.
3 to 4 years. Okay. So your take is buy the best.
Yes.
Yes. Rest of you, one by one, please.
Definitely buy the best. I also
think
agree
there
with
is a-
Dr. Medha. Even I have one, the one which I'm
Long
using for
time.
20 years. Long time
What
back.
goes wrong in the Indian ones? Why we should
Sir,
not buy an
I'm
Indian one? Try
using
and
Indian
stress on
one.
that.
Sir,
Try and
I'm
stress on that.
using Indian one for more than 12 years. No problem.
Yes. So
That is
where
also nice.
exactly is
The
the problem?
handling is
Perkins,
also
I'm
It is
using
in
important.
one
See,
hand, maybe
both
it is
use.
good.
Nay, Medha, why I asked you is this: if it is a single hand use,
yeah,
is Indian
Single
equivalent to Hux, right? Calibration wise also,
probably.
use wise also.
Yeah, what Tejaswini said, maybe if you are using yourself
Good.
and handling it carefully, it might be good.
Yeah, even the Perkins also is more than 12 years. Only the Prism I bought extra because sometimes the patients may be post-op or something. But otherwise, both are long. I mean, Perkins also is more than 12, 13 years.
Perkins is
And
also.
Indian applanation also, and even the imported one. All three is very nice. No problem.
Nay, what about the calibration part? Is they equally good
Calibration,
in the way we have it? The
Yeah,
readings
it's
also, are they
almost
matching with the
yes,
comparable or
yes,
not?
comparable.
Good.
If you are using yourself, I think buy a best one.
Yeah, if the finances afford and they want to do, this is especially for the person who is going to graduate into a glaucoma specialist, they have to buy it. But can a general ophthalmologist do it, as Tejaswini said, 12 years she's been using? This is why a valid point, because in the periphery of Maharashtra, a beginner slit lamp or the rest of the investment is good enough. If he is not practicing glaucoma, should he invest in Indian one and go ahead with it? That is why this question.
I think, sir, applanation tonometry is part of your complete eye evaluation. And even if you are not able to afford the best ones because you are just starting up, it's better to have at least the Indian one, because you want to do applanation tonometry for every patient wherever it is indicated. Most of the patients it would be indicated. Only thing is you make sure that, as was suggested, single use would be a single person use would be a better thing in for maintenance point of view. And as regards calibration, the point is what we do is calibration check. The calibration check with even Indian applanation tonometry is as good as what you would get with the imported ones. If there is an error, you have to send it to the company and they will take care. So there, your post-sale service has to be good.
How frequently you people check the calibration, and how is it really required? And if so, why?
I do it once in 3 months.
I do once in a week. When I start my OPD Monday morning, I do a calibration check. If it's still working,
Can you
it's still
explain
good.
how do you do the calibration in short?
Tejaswini.
Yeah, any one of you can just explain.
See, the company gives that weights and all, so we have to just once a month, I think, is sufficient. The proper procedure is there how to calibrate. So once a month I do. I don't do once a week. Is not. I don't think it's necessary.
Okay, fine.
There is a video, I think, I
Yeah.
don't remember who has posted on calibration of applanation tonometer. So it's
On
available.
YouTube.
All India, yeah, all the AIOS has posted that video.
Correct. Any more questions on the YouTube or this? Or somebody would like to add some tips, please go ahead.
I would just like to add that basically as a person who's probably practicing in periphery, any applanation, whether it be Indian or imported or whatever company that is, if it is calibrated well and maintained well, it's much better than going for a shear tonometer. So having a applanation tonometer itself, at least at the start, before you can have the funds necessary to upgrade to a better machine or something else later on, dynamic contour or something later on, at least start with the Indian one, maintain it properly, calibrate it properly, and luckily for us, many of our Indian companies give much better service and much economical service than the Indian imported companies. So I personally am in favor of starting ophthalmologist to go ahead with any APPA or whatever Indian instrument you want, and later on you can upgrade as required. It's not something which is going to cost you an arm and leg. People upgrade their phones every 2 years. So upgrading a applanation tonometer after about 10 years is not something which should be
We have heard about non-contact tonometers. Those who are not comfortable doing this, do you advocate or we should have an applanation tonometer?
No. If you want to practice glaucoma, you should have a applanation tonometer.
No, for a general ophthalmologist. See, we are doing it only for the general ophthalmologist under pressures.
Yes.
So if you can invest in non-contact tonometer, we can very well invest in simple,
point.
Not for investment. Those who are not comfortable by touching the cornea and all, and a non-contact say, ek biti baste na. So that
no glaucoma specialists would believe in non-contact tonometers. They will definitely believe in Goldman applanation tonometer.
Right. So question answered very well. Sangeeta has taken over. Any more questions on the YouTube?
That, sir, applanation is not a very painful technique. It is just a slight contact. So patients also will cooperate. So that's what, as they said, if you can invest in non-contact, you can invest definitely in an applanation. And applanation is not like gonioscopy. Maybe gonioscopy, there will be more inhibition from the ophthalmologist side also. Because even ours is a teaching hospital, I see that even though we tell the residents to do, there is a slight inhibition. So unless we, tell them to do it and they see us performing, then they learn. But applanation is not like that. So I think applanation is definitely the gold standard. And there is a, difference in the reading that we get from applanation, between applanation and non-contact. So non-contact is not so reliable. But for, if there is no applanation available, but there is an NCT available, definitely it is to be done rather than not doing tonometry at all. That is also.
How much is the difference between the non-contact and the applanation? It is on the lower side or the higher side?
Higher side.
Higher. Non-contact.
Higher always gives higher.
Yeah.
Okay.
So what I have seen is the value.
Then it gives a wrong reading. If patient blinks, then it gives a wrong reading.
Very high.
So if we record high, then we have to recheck the patient 2 or 3 readings. But it's not always high. But if patient blinks, then it gives sudden very high reading.
Correct.
What I have seen is like for pressures between 10 to 16, it coincides. But pressures above 16 is always high.
Yes.
So we had a very, very fruitful discussion. Any more questions on the YouTube or the webcast? Anmol?
No, sir.
Okay. So it's a very, very fruitful discussion. A lot of new tips had come up during the discussion. And I am sure, what is the go-home message each one would like to say before we wind up? Let's say sayonara to the our members, the audience.
My message is start doing everything.
Yes.
Start doing applanation, start doing gonioscopy, and start doing 90-day examination of the optic nerve head. Because once you start doing, then only you will learn how to do it, what are the intricacies of it. And the most important thing is, I always say that unless you do hundreds of each and everything, you won't be like expert in that. So then you should start thinking, okay, I have to do how many I have to do and how many every day I have to do.
Good.
Completely agree with Dr. Medha.
Yeah.
Completely agree with Dr. Medha. The same thing, even my message, start doing. See, for example, concerning my topic, gonioscopy, definitely that is more, relevant because you have to start doing gonioscopy. Then the fear will go. You will learn the technique. As you do more and more gonioscopies, you will become more, comfortable doing it. And of course, learn and improve in your gonioscopic findings also. Confidence also improves. Yeah.
Very nice. Yes. Tejaswini and Ashish and Swapnil. Go home messages for the audience, August audience will join.
Yeah, it's true that everybody should start doing everything. But just one point I missed that I want to tell that there is an inter and intra-observer error in doing applanation tonometry. Means for the same patient, if we do again, it may be 2 to 3 millimeter difference, and that is more with the beginners. So you can take 3 readings and take a mean of that. If we feel any doubt about our reading taken by ourselves only, and slowly this error reduces with experience. But it may be 2 to 3 millimeter difference in the same patient. If we take after 10 minutes the reading, it may be a difference. So nothing to worry about. 2 to 3 millimeter difference may be there. Okay.
Just want to add one thing. If there is excessive tears, excessive secretion, the pressure, applanation pressure might be low. And if the pressure is dry, the cornea is dry, the pressure might be high.
Yeah, that
so
I
you have to take care of that.
Just with the tissue paper, ask the patient to wipe out the extra tears and then take that.
Very, very nice tips, huh? Yes, Ashish.
Yeah,
Ashish
totally
and
concur
Swapnil.
with whatever messages we wanted to pass on. Although our session today is labeled as basic clinical glaucoma OPD procedure, I would tend to disagree. You were repeatedly asking, sir, about what should a general ophthalmologist do? What should a general ophthalmologist? See, these are all parts of routine complete eye examination. Every
Correct.
patient coming to a clinic, our first clinical examination must include these things. Right, like we take the visual acuity of the patient to refraction. These are also a compulsory part of basic clinical examination. So every ophthalmologist, whether in training or whether in practice, first consultation, these things have to be done. These are not any investigative modalities. These are clinical examination
Part of it.
techniques which need to be incorporated.
Very good.
Very
Very
nicely put, Ashish.
Very nicely put. Yes, Swapnil.
I agree with Dr. Ashish. At least all the patients should have at least one Herix grading. If not gonioscopy, they should at least have a 90-day examination before they are disposed of. Any patient who is walking into your OPD can be a potential glaucoma patient. So I think at least if not possible, if not AT is not GAT is not possible for each and every patient, NCT or a rebound tonometry, then a 90-day examination. And if those patients Herix grading, and if 90-day examination you suspect, undilated 90-day examination you suspect something, then probably you should investigate the patient further. But I think no patient of ours should walk out of the OPD without having a look at his disc, without having a look at his macula, and without having a look at his angles also, as well as.
So important tips you have given. We have Dr. Rajesh Joshi. He's a professor in what we say, Nagpur Medical College, GMC. Rajesh, your experience as a professor in a teaching institute, what are the PGs really asking for?
Yeah, in fact, we don't have luxury of using applanation tonometry here, because my experience is that whenever we install our applanation tonometry on slit lamp, it works for 3 to 4 months, and then again we have to repair it, and then again it lands up in some storeroom. So what I have planned at GMC Nagpur, that we have purchased Perkins tonometry, which is handheld, and every faculty is taught about this Perkins tonometry, and they teach our residents. So that is what we are planning to do. So we are shifting slowly from Schwartz tonometry to applanation tonometry, because I find it difficult, because as a resident, we were doing mostly Schwartz tonometry. So slowly our residents are now shifting from Schwartz to applanation tonometry. And routinely for every patient, we are performing tonometry, irrespective of for whatever complaints they come
Reason they come, correct.
Yeah.
And what about gonioscopy and all? Do they do on each and every patient?
No,
Just
not really.
no.
Whenever it is indicated, like glaucoma suspect, or if they find some problem with angles like neovascularization or foreign body, whatever. So in those cases, we are performing gonioscopy. Otherwise, not in each and every patient.
Which Gonio mirror do you have?
4 mirror.
Goldman's 4 mirror?
Yeah, 4 mirror.
Goldman's 4 mirror. What about optic now? I had evaluation with 90D.
Yeah, we have 78D. Every resident has got 78 and 90D. Either 78 or 90D. So they are performing optic nerve head evaluation on 78 or 92.
Good. I would like to ask the panelists, why do you prefer 90D over 78D? Because majority I have seen are doing with 78D. So what is the minus point in this not doing it? Medha?
No, actually what you are used to, that is the most important. This 78D, the pupil size, if the pupil size is very small, 90D helps. But if the pupil size is like average, 78 would help. But it is basically what you get used to it.
Okay.
78 gives a little magnified view than the 90 diopter. Especially useful when the pupil is dilated or little, more dilated. But with the small pupil, 90D gives a better, ability to visualize the fundus. Of course, whatever
Even
you're
the
used
depth
to,
of
that will be
perception,
more comfortable.
Vidya, even the depth of perception, the way you see the depth of the cup and this, is it well appreciated with 90 or 78?
I think it is similar because both the
No, I
lenses
don't
are, it is similar, but it's the magnification is more with the 78. I think depth of perception would be similar, but maybe slightly better with the 90D.
Actually, now it's like neuroadaptation. So whatever you get used to it, your brain gets used to it. It's good.
Okay. So, thanks a lot. I would really thanks each and every speaker. Well, it's a very simple procedure, but a lot of the way just Dr. Ajay Joshi said, the residents are not well used to it. They are now shifting from shorts to Perkins and then later applanation. Applanation, they say multiple uses, it gets spoiled. So this was a very valid thing that we did today under the platform of MOS, trying to cover the basic procedure. Of course, Ashish also says it's an integral part of any basic eye examination in an individual ophthalmic practice. Everybody should do an applanation tonometry. Try and see the gonioscope if you feel there is a doubt. And of course, 90D, it is also quite easy as Dr. Medha rightly showed. So a big thank you to each one of you, Dr. Medha, Dr. Vidya, and Dr. Tejaswini, and for the lively panel discussion, Dr. Ashish Thul and Dr. Swapnil Kothari, and a very nice moderation by Dr. Sangeeta Kakade. Sangeeta, would you like to add something, as you are also a glaucoma specialist, your views on this? And
no,
then
we have
before
already
we go
discussed,
for
sir. We glaucoma specialists are all on one side, sir.
on one
The
side.
same
So you're with the view. I said nothing contrary. So now we'll have a 1-minute video from the enrolled people before a vote of thanks by Dr. Honorary Secretary Dr. Ajay Joshi. Thank you very much, each one of you.
Thank you, sir.
Yeah. Anmol, Ashwin.
Ashwin is there, I suppose.
Yeah. Please show your video quickly. The enrolled people are also the real backbone. Very good technical support. All my webinars have been very well supported by the technical team of enrolled, and of course the audience who have been there. Real big thank you for them. Be there till 10:30. Over to you, Rajesh.
Sir, a big thank you to yourself first for this novel idea of this webinar on the basics of this glaucoma workup before finishing this thing.
Yes. I had that thing because initially when we started our practice, we faced all this. No? So I feel the freshers should be shown the nitty-gritties of this. Everybody gives the book version. PPT में सब आ जाता है, but live what we showed just now, कितने angle पे कौन सा दिखाना, how much is the illumination, why it should be dark, everything was well explained in that 5-10 minutes of videos. So good. Yes, Rajesh.
Really great learning webinar for residents, fellows, and general ophthalmologists for the ongoing Glaucoma Week celebration. Kudos to our vibrant president, Dr. Taswala sir, for his initiative. Thank you, Dr. Tejaswini, Dr. Vidya, Dr. Medha, for highlighting on various aspects of glaucoma evaluation. Thank you, Dr. Ashish, Dr. Swapnil, for agreeing to be panelists and highlighting on various aspects of glaucoma, particularly tips on gonioscopy and applanation tonometry for our colleagues and residents. Thank you, Dr. Sangeeta, for conducting the session so well. I'm also thankful to all those who joined on virtual platform for today's webinar. Thanks to Entor for the technical support. Thank you all.
Thank
It was
you.
really
Thank
a
you.
wonderful.
Just a request for all who are in Pune to be there for the glaucoma walk tomorrow, 7 to 8. The meeting at JDH. Be at around 6:50. We have the deputy mayor who's going to be there to flag off this rally, and also the ACP from that area, Swargate area is there. And Dr. Shrikant Kelkar has first time agreed to be part of the rally tomorrow. So we have the special invitees also. So all of you, Vidya, Tejaswini and Medha,
Yes,
all your
Definitely.
residents,
yes,
yeah,
sir.
try and see that you make it.
Thank,
Thank you very
thank
much.
you. Thank
We
you.
are, we
Thank
also
you, sir.
having one in
Thank
Nagpur
you, sir.
tomorrow morning.
Yes.
Great.
Yeah. So you can request on this platform to everybody to attend, the Vidarbha
Yeah.
people also.
I'm sure whoever
And
is in
let's
Nagpur.
post all this thing so it becomes an impetus for rest of them to follow. Of course, tomorrow is the last day. Majority have already held the rallies. I am extremely thankful on behalf of MOS. They have taken a cue and did the public awareness. We also had the Akashvani program on public awareness. All zones were involved, and we have a TV show also coming up on the 24th, where we have the glaucoma specialist going to talk on the public awareness on glaucoma. Thank you, everybody. Take care.
Thank you.
Have a nice
Thank
weekend.
you.
Thank you,
Yeah.
sir.
Thank you, sir. Good night.
Yeah.
Okay, you're taking
Thank you.
gallery view.
Gallery with
क्या
picture.
gallery भी लो भाई बराबर है Medha also remembers. I
No,
told
no,
him.
someone
there
put
was
a
No,
there was a
before
message.
the
There
panelists
was a
sign off,
message.
let's have a gallery view. Everybody smile, please.
smile, please.
10:30 रात को smile
I
करो.
will also take one photo.
Yes.
1, 2.
Yeah.
Hello.
I think Medha का सबसे ज्यादा आएगा 100 मेगापिक्सल का कैमरा है.
Ah.
पोस्ट करा था POS ग्रुप मध्ये.
Yes, yes, I
सगळ्या
will
ग्रुप
do.
मध्ये पोस्ट करा.
I will do.
चलो बाय.
Chalo, bye.
Thank you.
Thank you.
Thank you,
Thank you,
everyone.
everyone.
Thank you, sir.
हेड काउंट बताओ भाई. Ashwin and
Night.
Anmol. Post it on our group. Chalo.
Yeah.
Good night.
Bye.
Good night.
Good
Bye,
night.
thank
Ashish,
you.
Bye.
Swapnil,
Bye, thank you.
Medha,
Yeah.
Bye.
Vidya, and
Bye
I,
all.
Tejaswini,
Bye, bye.
Rajesh.
Thank you, sir.
Bye,
Thank
bye.
you, everyone.
Thanks.
But